Hi, everybody. Well, welcome to the EGP Learning Podcast with Andy and Gandhi. And we're going to talk about something slightly different today because it hasn't actually happened yet, but we kind of think it may do, which is the end of lockdown and what that means, particularly for primary care. How are we doing, Andy?
Yeah, I'm good, thank you, Gandhi. Been another busy week at the practice in the PCN and at the COVID hub, or clinical management centres as we call them in Nottingham. But yeah, as you say, beginning to think about the possibility of life after COVID. This may not be with us forever. Lockdown may end, and things may be different after COVID. A lot's changed.
Yeah, and there's going to be lots of speculation about what the world and life will be like post-lockdown. I think many of us are expecting it to not suddenly be just go back to normal, that it will be a gradual introduction of what we do. But I guess we wanted to focus a little bit more about what this means for primary care in particular, because primary care has done amazing things over the past month in terms of how it's adapted and changed and tried to deliver ongoing healthcare to the population despite the challenges we've had. But it's going to be different, don't you think?
I think so. And I think what has been unique about this episode is COVID-19 has touched every aspect of people's lives. So it's not just been an event in primary care, not just been an event in wider healthcare, but it's also affected how people do their shopping, how they relate to their family and friends, so much. And the themes have been very similar for each of those areas of life. There's been a lean towards technology, a lean towards video, and a little bit of self-resilience and self-reliance as well to facilitate all of those changes. So I think there might be some good themes to build on for lasting change and moving primary care and everything forwards with the help of technology.
But yeah, so we talked about how COVID's made so significant changes, I guess, to our lives and the lockdown that as a result of that. Primary care, as we mentioned, has just gone through seismic shift. There is no other way of describing it. It's like a paradigm shift in primary care, effectively. And with that, we've got various different things that come into play. So we've got digital management systems. We've got video consultation has been a massive part of it to try and reduce face-to-face contact for safety and all that kind of thing. And obviously the way it impacts our lives and to a degree, even the way people are attending. Many of you are probably going to realise this later today, but there's going to be national campaigns to try and suggest that the NHS is actually still open. Because one of the weird things, we're seeing a drop-off in the number of things like heart attacks and other kind of health issues that you wouldn't really expect to change despite COVID. You'd still expect roughly same number of people to get heart attacks and that kind of stuff. And because there has been this reduction, there's this perception that possibly the NHS is shut. Clearly it's not. But the general practice and routine health issues and other health issues in particular still happen and that they may still need dealing with. I mean, what's your experience from that, Andy?
Yeah, so in the surgery, they're beginning to get busier again, actually. And I think a lot of people are now beginning to access healthcare again, having been quite worried about accessing healthcare. One, because they felt that the NHS was overwhelmed, and it could have been by COVID. And maybe it came close in some areas, but areas like ours in primary care weren't necessarily overloaded. Also, a lot of people were very worried about coming out, breaking their lockdown, going to a place where other sick people might be going as well. So a lot of people were genuinely worried about picking up COVID-19 within the surgery and within primary care. And I think a lot of people have now sat on things for a while. They're beginning to realise that they do need to see the GP, see the doctor. So we're seeing a bit of an uptick in terms of how busy we are, but people have stayed away for a while. And I suppose there's two worries, isn't there? So on the one hand, what's been happening to these people who we would have expected to have a heart attack, stroke or other serious illness? Have they not had them? Or have they had them and not sought appropriate care? And probably statistically, logically, the latter is more likely.
Yeah.
The other concern, Andy, that I've got is we've postponed a lot of routine work over this period of time, and patients will have postponed accessing a lot of routine care over this time. So I've just got a feeling that there is a wave coming of increased demand for us just over the hill of the next few weeks. So I'm just thinking about how to do that.
Obviously secondary care's had to stop and cancel a lot of its routine monitoring. There's the impact of all those patients that haven't had their chronic health specialist issues dealt with that will need that's restarting or continuing. We will have, like you say, the patients that may have had grumbling issues that if we'd seen and dealt with could have been sorted, but may end up becoming something more unpleasant as a result of it. And just, it's the Johari's window of the unknown unknowns. You don't know until you kind of come across them, and we're not coming across them right now, which is part of the challenge, isn't it? Because it's both created by the system, but it's also in a sense created by patients not wanting to put themselves at risk for something else. And then how does that impact things? It's an unusual place to be.
It's a funny, it's been a funny old world the last few weeks. So Gandhi, shall we pull it together into some themes? So I think we've got it down, the areas that to cover in terms of how things might change. So there might be some changes to the demand, but there might be a lot of changes happening in these areas. Will they stick? That's the debate. So demand management, appointment systems, that's changing an awful lot. Patients, self-care and resilience. So I think some of those people are not coming because they found another way to deal with their problem as well, which I think is absolutely great. So I think that's something to talk about. Video is a whole issue in itself that I think has been enormously useful in many ways. People are beginning to think about managing those long-term conditions. We may be in lockdown for a while, and people will need their routine reviews. So we need to think about how we can perhaps use some of these technological innovations for that. Working with colleagues is an area that's changed, and looking forwards, can we change the wider multidisciplinary team and how we're communicating and working with them? Those are wow, that feels like a lot to cover in 25 minutes, but those are the areas that we drafted out.
Gonna give it a go. So I guess in terms of demand management and systems, so many patients may not be aware of this, but I'm pretty sure everybody in primary care is aware of this. By the end of the month, that we general practice will move to what's called a total triage system, and this is a contractually mandated thing, so we have to do it. We've been told we have to do it, and it's not been delayed because of COVID. But effectively, using a digital front of house to try and help patients understand where they need to navigate to when it comes to their healthcare needs through primary care. So whether that's self-care, whether that's going to the pharmacy, whether that's going to seek direct self-referral services like physiotherapy, mental health, that kind of stuff, or whether they do actually need contact from the practice. And I use that term quite clearly. It's the practice contact. It's not necessarily GP contact or reception contact. It's putting it into the practice system, and then from that comes an outcome of what the patient potentially needs. So is it, well, they just need a prescription sorting, so that goes to the prescribing clerks? Is it that they need their referral chasing, in which case it goes to the typists, the secretaries, that kind of thing? Or do they need some sort of clinical outcome? So, and out of that, what do they need? Can it be dealt with by a nurse? Can it be dealt with by a healthcare assistant? Can it be dealt with by a physician's associate, pharmacist? Or does it need a GP? And we're going to see that system go live nationally by the end of the month for many places. And I think it's not going to be a big bang, I don't think, for many places, unless practices choose to use that option of everything goes through that mechanism. But I think across the country, what we will see is, change, massive change again, even though we've just done it.
So Gandhi, can I just clarify this? So is this patients will, the requirement is that patients have a choice of a digital triage first option, presumably? Yeah.
So patients have the choice of a digital first option. I have heard of some places where they will be prioritizing patients to go through that digital first system, so that the telephone access and that kind of stuff will be actively disencouraged. So not refused, because you can't do that. That's not safe and that's not sensible. But like some places have considered removing their telephone from their website, so then you can't actually call them. You have to go through the digital route first. Or actively supporting patients to do that by every contact. Have you thought about going through the online mechanism? Let's walk you through it as you call the reception, and then reception basically do that for the patient to show them what they could have done themselves and save time for themselves as well, potentially.
Yeah, so that's good. So we're not going to be disadvantaging those people who can't use these systems for whatever reason.
Absolutely not, and we should never be thinking about doing that.
So Gandhi, this is going live in a month. What is this going to look like at your practice? I know we've got a lot of work to do at my practice.
And I think similarly, so across Nottinghamshire, we're using a system called Patient Knows Best, which is effectively a system that allows patients access to their notes. And then they've created some extra bespoke services for the Nottinghamshire area that also includes those kind of things that we talked about. So form management, in the sense the patient documents a query that goes through to the central team to then filter into where it needs to go, and then hopefully that comes as an outcome of the right person seeing it for the right reason. And that's the theory behind it. It gives patients the ability to do standard things like request their medications, look at their results, those kind of things as well. Other areas are using other systems. So there's a variety of different versions. There's Clinic, there's Ask My GP, and eConsult, Engage Consult. There's loads of them, absolutely loads. And that's just to name a few and things. And often that may then mean that the patient gets a contact from a clinical perspective based on telephone triage, potentially. It may not be a direct reply back, a single reply. It may be a telephone consultation in return, maybe a video consultation, or it may be a face-to-face or a visit. It depends on the clinical situation. And I don't think we've got time to debate how that works here, possibly a future episode. But if
yeah. So Gandhi, so at my surgery, things have changed dramatically from how they were a few years ago, and we've lent quite a lot on. In fact, we've gone telephone first for everything. Initially and primarily at the moment to risk assess for COVID-19 infection and make sure people end up either at the CMC or at the surgery if they're potentially COVID, or at the surgery if they definitely need to be seen and they have non-COVID illness. We then convert to video if the GP or the A&P feels that that's going to help the quality of the assessment, and then as a fairly small proportion currently, we progress to a face-to-face appointment. And that we all feel that that's working quite well. And that model, perhaps with an extra step at the beginning with some total online triage, we feel that might be the way to go. And I'm just wondering, are you doing something similar? One, do you think it's better than what was before, and do you think it sticks? Because I think we like what we're doing, and we're going to be thinking about whether it's something that's appropriate to continue with. What are your thoughts?
So I think we're probably doing something fairly similar. So we have been using telephone triage for several years as a mechanism for managing our patient demand to make sure that they try and see the right person at the right time. So patients in my practice area won't be unknown to that kind of system. And we've added video as a bolt-on because of the situation, which has helped. And I think some patients found that really useful and some patients found it less useful. And that's inevitably down to tech issues more than anything else, the connection, clarity of the visuals and that kind of stuff. I think the kind of triage stuff that online consultations can bring will be potentially useful because that will help to release your your reception team capacity, so that you're not having this influx at 8 o'clock in the morning of 500 people trying to ring the practice all at the same time. That's the hope. Let's put it that way. I think that patients can then actually put these in and then they're dealt with in a timely manner by a process that means that then they get to the right place. So, for example, the patient who's ringing, you don't know who's ringing up for a prescription, who's ringing up with a heart attack, and you don't know who's ringing up with a cold until you actually answer the call. And the benefit of this mechanism is that whilst they all come in into your inbox as such, you can filter them out potentially a lot quicker by scanning what the information is and making sure they go to the right place. I mean, clearly you'd hope that the person having the heart attack gets the response, contact A&E, don't come to us, because that's clearly the wrong thing to do. But that's how it hopefully should work. Will it be that way straight away? No, I don't think so, because there's, first of all, the uptake by patients to do that, and that's going to take time. And that's not going to be, like I say, a big bang, I don't think. And secondly, the other part is the part where digital engagement really tends to fall down on is, in my personal view, the more deprived areas, because you have the added complexity of things like digital resources, digital literacy, and language. And all these systems are designed to work in English. They don't work in other languages, and particularly when you've got a plethora of non-English speaking patients, so various different languages. I think at our last count we've got over 20 different languages that we have to deal with in our practice. No system can cope with that effectively. And do you trust Google Translate to be your translation mechanism if that's the case? And I know CQC's view on that is absolutely not, which I still disagree with, but hey, that's a separate matter.
Gandhi, so before we move on, so do you think it's a given that we're going to end up in this new world as we described, with online, telephone, convert to video. If clinician feels appropriate, then direct, see face to face, see the right person at the right time. Sounds great. It's working well. Is it a given that we're going to transition into that post-COVID, or are things going to drag us back to the way we were before? What do you think?
I think the thing that will drag us back will be clinician engagement. And I say this slightly controversially, I guess, because so many of our colleagues have taken to the challenge of what COVID has brought to us and met it quite clearly. But I think there will be some resistance and some need for many to want to go back to the previous system. And actually, I think that this is a potentially much better way of doing things. I think it's important to remember there are still patients that you will need to see face to face, and that will need to be their first point of contact. Those patients with learning disabilities, those really complex patients that just cannot engage through that mechanism. But does it open doors for other patients? Definitely. Does it open doors for practices to work in a different way? Absolutely. And I think that's the part that we can't forget, because I know so many of my colleagues through social media and stuff who have said that this new way of working has brought a different appreciation for how we do things to them. And I think that's something not to be forgotten. Does it mean less personal contact? Absolutely not. It depends on how you deal with it. Yes, it does right now, because we've got a situation that dictates that face-to-face contact isn't the best way to do things right now for certain things. But I think once that calms down, remembering that not everything has to be done face-to-face, but at the same time, there are definitely some things that should be done. And it's trying to get that happy balance. And I think that's where we will end up at if people let it.
Yeah, here. I agree. I think we won't go back, actually. I think the change is probably going to be sustained for long enough and involve enough of the clinicians such that everybody gets a good exposure for a reasonable period of time to the new ways of working. And I think that'll help us stick. Shall we talk about patient self-care and resilience next?
Yeah, sure.
Because where are they? We touched upon this. So some are probably quietly having health events that we'd very much rather them see healthcare for.
Yep.
Some of them will be managing more effectively themselves, presumably. Some people will be struggling, obviously, but there must be a group of people who are managing better. And I'm just wondering, what do they do? How are they doing that? And how can we keep them doing that afterwards? Have you had any thoughts on that?
I think so there's various different streams to this, isn't there? There's the viral illness management aspect of things, and what I genuinely hope and pray for, that after this, the message that you don't need to see a doctor for every possible viral issue comes to play. Because I think, unfortunately, over the past few years, we've increasingly got to the situation where if you have a temperature, you have to see the doctor. If you have a sneeze, you have to see the doctor. And that has been the case. I know many people feel that isn't, and that we have some cohorts of patients that can self-manage. We definitely do. But if you look at it from a perspective of, again, I'm going to use mine, working in a inner city practice with lots of issues of deprivation, that kind of stuff. The clear message that patients have come through is, if I'm unwell, I see a doctor for absolutely everything. And that's the public health message we have been pushing out for many years. And that causes challenges, because I've literally seen patients that have coughed twice and come to see me because they've coughed twice. I mean, I cough twice sometimes when I have a drink, and what I hope is that we see better management of initial health issues. That's not to say that if you have a cough for 10 weeks that you stick it out. Clearly not. That shouldn't be happening. And if that's the case, then the message has definitely gone wrong again. But what I hope is that, with some of the digital stuff, that we see better reassurance for patients and acceptance of the advice as well, that things are okay. In terms of people not attending as much, one thing I did wonder, so because of lockdown, people are potentially less active. So they're not running around as much, they're not having to go to events, not having to have the stresses of, all the other things that come with normal life.
Not falling off the ladder when they're doing the DIY.
Exactly. Yeah, they're not doing the things that potentially put them at riskier situations, or like they say about the people with heart attacks, you're not having the people getting stressed out by having to have confrontations at work, or having to organize themselves, their kids and everybody else to get to point A at 8 o'clock in the evening, because actually life has just slowed down a lot. And I wonder if that's partly the situation, but I also agree that the drop off has been significant, and there is a genuine absolute worry that we have patients sitting at home who are just sitting on health issues that do need some sort of clinical discussion at the very least, if not clinical contact and processing. But even that's a challenge. So over the past week, like I say, it's started to increase. And I've had patients who I've said to them, look, I need to have some blood tests done because I can't analyze this further without more information. And they don't want to go have them done because they don't want to risk potential contact of COVID. I'm like,
yes.
But if you don't have that done, I can't help you understand if this is something really bad or something not so bad.
Gandhi, that's really interesting. I've had a number of my patients who sometimes they come to the surgery maybe more often than they need to, but now you have to convince them to come. You speak on the phone and say, no, you need to come. You need to have some blood tests, and we need to do an ECG. We need to actually physically examine you, and you need to twist their arm to come. Yeah. It's been fascinating. I was going to make a slightly different point in terms of something that I think will help cement a bit of change potentially if we handle it right, and improve the resilience of the population maybe longer term. Because I think we've all had a big event together that's now part of the national story, the national narrative. We've had this period of time when people didn't see their doctor so much. Perhaps there's been a lot of people who have experienced a viral illness, a cough, a self-limiting illness from start to finish without needing health intervention. They perhaps used some initiatives, sought some advice themselves, and they lived through it. And a lot of people did that. And it's something that we can talk about, that we can reflect on in the future when we're trying to get this point across. And these events that affect everyone simultaneously are really rare in modern society. And I think we can draw on that, as a story that we continue to tell one another going forwards. Not very technological, but I think it's healthy.
Yeah. It is the narrative of that information, isn't it? It feeds into the perspective that these patients and also the clinicians, it's important to take this back to the clinicians, that not everything needs active management, the whole concept of time as a healer.
We've probably all become more resilient, patients more resilient, but also as GPs, we've probably become a little bit more resilient, and it's challenged our risk management in a way that hopefully will produce, a better outcome. You never know. There's two sides to every story, but interesting. Shall we move on to video? I've got a few observations I wanted to make about the use of video. I don't know if you.
No, go for it. You lead on this one.
So I think how the adoption of video has played out may be different because of what's happened with COVID compared to what was happening before. Because before, the adoption of video was looking like it was going to be slower, and I think it was actually quite driven by the centre, by NHS England, by an assumption that it's what patients want, and it was going to be a solution to an access problem in terms of patients wanted more convenient access. And I think that's the direction it was coming from, and I think that was meeting with a bit of apathy from doctors potentially. Because that's not a problem that they experience. They've got lots of people getting lots of access to them and a lot of demand on their time. So the problems they were solving they weren't aligned with doctor needs, if you know what I mean, or healthcare service providers' needs. And I think COVID's come along, and actually video has been really, really useful for doctors, nurses, clinicians to manage the demand. It's been suddenly a useful tool because you can't see the patients face to face. Telephone has lots of advantages, but lots of drawbacks, and actually video in certain situations really build on that. So I think what we've actually seen is a massive increase in video consultation, but I think it's been quite clinician-led and clinician-managed. So when I do a video consultation, what has normally happened is the patient has had a telephone consultation first, and the clinician, so me, if we're dealing with mine, but generally speaking, the clinician determines that it's a good use of resources, the clinician time, the patient's time, to do to convert to a video consultation. It doesn't happen every time, and at the moment it's not really a patient choice to have that video consultation. It's in the hands of the clinician, so we do it only when it adds value, and then afterwards we either resolve the issue on video or we resolve the issue face to face by bringing them in, and that's felt really useful to the clinicians, and probably makes good efficient use of resources and clinician time. So it's almost been used to solve a different problem to the problem that was being used to solve initially.
Yeah.
And I'm hopeful that we've sort of taken back control of that agenda in a way, and that we can continue that way, because I genuinely think that is better for patients. And I think there will be perhaps a bit of movement towards providing it as a convenience issue. But when you've only got so many GPs and so much GP time and so much AMP time, the considerations of making efficient use of that resource is important to patients as well. That should be on their agenda. That was an observation I made. I mean, what do you think, Gandhi? Have things played out differently with video because of COVID, and could we be heading to a different place with video than we would have headed to without COVID?
I think what you said, the fact that the control of how video works has been given back to the clinicians rather than being led by the patients, has meant a better uptake by clinicians in terms of using it. Now, clearly this has happened because we've got the situation where actually being in the same room as a patient is actually potentially harmful. And we've rarely had that situation in healthcare. It's not the common situation that we end up finding ourselves in. And because of that, not only are the clinicians pushing to want to use video for those situations, but actually so the patients, because the patients are worried about, if I go to see the GP, I might get COVID from them. So they don't want, in a sense, to see us unless they absolutely have to as well. And I think because of that, that's why we've seen such an interesting and increased uptake of it. And I think because of that experience, clinicians have also found actually it's not as bad as they thought. But you're right. I think that the focus should always be telephone first and upgrade to video if you need to. Because the other thing to remember is that you don't always have to upgrade to video. You can, like we've seen with companies like Accurix provide, you can use photo. So, okay, you've got a rash. I kind of want to see what it looks like, or you've got a swelling joint. I'd like to see what it looks like. Send me a photo rather than going to video. Because when you go to video, it's more user involvement that comes into it. It's a more complicated process than, for example, just sending a photo or just picking up a phone call. And because of that, that's time, that's experience that the patient may have. Because if it doesn't work so well, then they're less likely to want to do it again, because they'll remember, the last time I did it, it didn't work. And you know how that is in life. If you do something and it doesn't work, you're probably less likely to try it again. Although you may give it a go, it's a block, isn't it? So I think one of the things that we are seeing is that element that the priority, in my view, is still telephone first and then upgrade to video when it's suitable to do so. And I think the benefit of that is that you will have better consultation flows. I think you'll have better meeting of the demand, but also for patients, it works more effective because you don't need video for everything. This perspective that you need to see the patient for absolutely everything is not correct. I think for new contacts, it's a slightly different thing compared to follow-up contacts as well. So, a patient I know really, really well will more than happily speak to me on the phone because they know me, they've seen me, they kind of know what I'm like. A new patient I've not come across before, are they more likely to potentially want to know what I look like? All those kind of non-verbal stuff that comes with it, that would probably make them more reassured because they're seeing somebody. And it's important not to forget the impact of seeing somebody can have on a person kind of thing. So, pros and cons, but I definitely think that it's had a benefit and that we shouldn't go back to what we were doing before. But
so I think we were potentially heading in a direction that wasn't going to be the best use of video. And I think
agree.
Suddenly, adopted, clinicians have really adopted and taken to video and, see it as a useful tool. And I think we'll head in a better direction.
Yeah. And I guess, so both you and I were working as part of the digital engagement team to bring video to Nottinghamshire. And our focus was definitely different to what it is currently that we're doing, absolutely. Because we were trying to identify the situations where video would be more useful. And we had a selection of things that we thought video would work really well for. But actually, what we're seeing now is that it's already done to a degree, but it's still different to what we were thinking, isn't it?
Yeah, well, I mean, the answer, Gandhi, is not what I think we were heading towards. And the answer is just start with telephone and let the clinician decide using
exactly.
Perfect. It's a great answer, but that wasn't where we were heading. So that's really, really interesting.
Yeah, so I think we're going to take a pause there. We're going to continue with our post-lockdown primary care discussion in our next episode. And we've got more stuff as ever coming out for you guys. And we will continue this discussion in 2 weeks' time. So definitely make sure you join us, engage, comment.
It's a cliffhanger.
Yeah.
It's a cliffhanger episode. They've got to come back. Fantastic.
You've got to come back to find out even more of those amazing nuggets of things that we've got to talk about. And we've got some really cool ones coming up as well. Definitely put a like and subscribe to this channel, and on the podcast, similarly subscribe and leave us a review on iTunes. And as always, EGP Learning is here to help save you and your patients time by taking that to your primary care and learning. And we'll catch you in the next episode.
Okay, bye guys.